What is the formula to check the filtration fraction? Yeah, that's why you can say that it is a higher low. 1, 2, 3. What is the formula to check the filtration fraction?
G for renal plasma flow.
Our renal plasma flow. And if the GFR is a high, means that the filtration fraction will be the high. And in another cases, in which the filtration fraction will be the high. For example, if a patient presents to us with a history of renal stones or obstruction in the ureter or ureter stone, in this case, the filtration fraction will be the higher low.
In obstruction,
Yeah.
the GFR will be decreased, no effect. It's effective in decrease.
Filtration fraction will be decreased. Good. If a patient presents to you with a history of hypertension, hypernatremia, hypokalemia, and metabolic alkalosis, what will be your diagnosis? Hyperaldosteronism. In hyperaldosteronism or the Cone syndrome, what will the plasma renin level?
In primary renal level will be decreased.
Okay.
If there will be a secondary, then renal level will decrease.
Can you explain any type of the secondary hyperaldosteronism? Heart failure, other than the heart failure, liver cirrhosis, nephrotic syndrome, heart failure. In these, we see the secondary hyperaldosteronism. And if a patient presents to us with a history of hypersodic hypertension, palpitation, perspiration, pain, what will be your diagnosis? In the treatment of the pheochromosome, which investigation you will perform? And which test you will perform in the ectopic? What is the most common location for the ectopic pheochromocytoma? Bladder. Bladder is the most common site of the pheochromocytoma. And if in the option there is not mention of the serum metanephrine, then you will go far toward the which option? Mandelic acid and serum. And another serum catecholamine. Epinephrine, norepinephrine will be raised in this patient. And if a patient presents to us with a history of hypertension, hyperthyroidism, and also the hyperpigmentation, this patient also have the headache, what will be your diagnosis? If a patient presents to you with a history of hypertension, hyperglycemia, hyperglycemia, hypertension, and hyperpigmentation, and headache, what will be your diagnosis?
Sir, Cushing syndrome.
It will be Cushing syndrome or Cushing disease?
Cushing disease.
Cushing syndrome is saying, and you are saying Cushing disease is also saying Cushing syndrome.
No pigmentation.
Huh?
Pigmentation present.
Hyperpigmentation. Huh?
Cushing disease.
Cushing disease. It is not a Cushing syndrome because there is problem with the headache and the brain. So we will say it is the Cushing disease. And if a patient, what is the? Can you tell any type of the Cushing syndrome? In the Cushing syndrome, where is the location is the core of the tumor?
Cushing syndrome can be primary problem in adrenal gland.
In ectopic, I am asking, in which hyperpigmentation occurs, ACTH level will be the raise.
It can be a small cell lung carcinoma or carcinoid. And it can be a renal cell carcinoma.
Renal cell carcinoma. And if a patient presents to us with the history of ACTH dependent Cushing syndrome, how you will differentiate between the ACTH dependent Cushing syndrome, it is a Cushing disease or ectopic?
If ACTH will be decreased, it is ACTH independent. If ACTH will be increased, it means ACTH dependent.
I am asking about ACTH dependent.
I don't
Test. And if a patient presents to us with a history of hypertension, hyperglycemia, and the level of the ACTH is a decrease, and also the MSH level is a decrease, but the contralateral adrenal gland hypoplasia or atrophy seen on the CT scan, what will be your diagnosis?
Unilateral.
If unilateral adrenal adenoma, good. And if a patient is present to you with a history of hypertension, hyperglycemia, and bruises, and also the patient have the stria, mark, and upon investigation CT scan there is a bilateral adrenal atrophy, see what will be your diagnosis? And ACTH level is low in this patient. Ectopic. In ectopic there is a level of the ACTH will be higher. Exogenous. It is exogenous. That's why the level of the ACTH is low. And if a patient presents to us with a history of epigastric pain, loin and groin region, and also the recurrent history of the renal stones, psychotic tone, he is very aggressive in nature, what will be your diagnosis? You will choose the hyperparathyroidism or hypercalcemia.
Hypercalcemia.
We will go toward the hypercalcemia because it is all the signs of the hypercalcemia. Yes. And hypercalcemia are seen in which condition?
Hypercalcemia can be seen in hyperparathyroidism.
Yes.
Can be seen in multiple myeloma.
Okay.
We can see hypercalcemia due to vitamin D overuse.
Okay.
And we can see hypercalcemia if there will be metabolic alkalosis.
Constipation.
You can't see Nimda. You see these symptoms due to hypercalcemia. So, which of the respiratory disease is related to hypercalcemia? Any respiratory disease? Sarcoidosis associated with the hypercalcemia. And if a patient presents to you with a history of recurrent bone pain, also the polydipsia, polyuria, peptic ulcer, and upon investigation, the level of the parathyroid hormone is elevated, serum calcium level is elevated, and serum phosphate level is low. What will be your diagnosis?